I hope the stream has started. This is my first stream on this channel. Yeah, so let me just start up the promo timer. I hope everything is going great. Yeah, everything has started. Okay, so let's just get into the studying part of it. 50 minutes studying, and then we take a break if we feel like. So let's get to solving questions. It's important to stay hydrated. Okay, so proteinuria. What does proteinuria do? Real adults made less than 150 gram of proteins. Less than 150 gram of proteins, total protein is normal, and less than 30 milligram of albumin is normal. Proteinuria greater than 1 milligram of protein per day. Most common Ghati labne. What is the most common types of Ghati labne? No, no. What is the number? No, 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 no. Approach. Proteinuria approach. Urine dipstick came positive. Urine dipstick came positive, so proteinuria, proteinuria present. Excretion of spot morning creatinine ratio হচ্ছে 30 to 35 হলে মাইক্রোঅ্যালবুমিন হয়ে গেল, আর এদিকে হলো ম্যাসিভ প্রোটিন হয়ে গেল। মাইক্রোঅ্যালবুমিন কজ হচ্ছে আর্লি ডায়াবেটিস, এসেনশিয়াল হাইপারটেনশন, আর্লি স্টেজ অফ নেফ্রাইটিস, স্পেশালি আরবিসি কার্ডস। আর এখানে হচ্ছে 30 to 35 ম্যাসিভ প্রোটিনুরিয়া going on. No, I don't think so. ম্যাসিভ প্রোটিনুরিয়া এখানে 30 to 35 ইয়ে ঠিক শিট করে দেই। এখানেও এটাকে দিয়ে দিই। কোথায় গেল? I should have been studying right now, but I'm doing bullshit works. আরে ছাগল, not this one. Should be great, but পড়াশোনা করো। The only problem is this is getting fucking stupid. এটাকে উল্টো করতে হবে না? এটাকে যদি আমি exactly transform rotate 180 degrees করি তাহলে কি করতে সুবিধা হবে? I think so. কিছু তো সুবিধা হবে লিস্ট দিস বেটার দেন বিফোর। আর যখন ওদিকে আসবে তখন এখানে এরকম করে দেবো, ওখানে এরকম করবো। গুড, ঠিক আছে, নো প্রবলেমস। হুম, এখানে এটা অর্থশ্রেণী প্রোটিন এরিয়া। চলো প্রোটিন এরিয়া আছে, প্রোটিন এরিয়া 24 to 25 spot carrying ratio, micronutrient essential is early diabetes, essential hypertension, early stage of glomerular nephrititis, especially কাজ এখানে কি হচ্ছে ইউরিন প্রোটিন লেভেল যদি 300 to 3005, why the fuck আচ্ছা 3500 হচ্ছে ম্যাসিভ প্রোটিন এরিয়া, why the fuck have you differentiated that? যাই হোক, for some reason we differentiate 300 to 350, 3500 হচ্ছে লেভেলটা, ঠিক আছে, 3500 হচ্ছে লেভেলটা, আর এখানে 30 to 300 হচ্ছে লেভেলটা, ঠিক আছে, 300। আচ্ছা, এখানে আর বেশি দেখবো। কনসিডার কজেস মাইক্রোঅ্যালবুমিন আর ইন্টারমিডিয়েট কনজেস্টিভ হার্ট ফেলিয়ার ফিভার, কনজেস্টিভ হার্ট ফেলিয়ার ফিভারে হতে পারে, এক্সারসাইজ করলেও হতে পারে, ঠিক আছে, মোটিস নট মডারেট, বেসিক্যালি নট ম্যাক্রো। নেফ্রোটিক সিন্ড্রোম, ডায়াবেটিস, নেফ্রোটিক সিন্ড্রোম, ডায়াবেটিস, হেমাটোডিসিস, মিনিমাল চেঞ্জেস, এমপিজিএন হতে পারে। আচ্ছা, ইউপি করতে হবে, ইউরিন প্রোটিন ইলেক্ট্রোফোরেসিস। আচ্ছা, ইউরিন প্রোটিন ইলেক্ট্রোফোরেসিস করবো, ইউরিন প্রোটিন প্রসেস করবো, সেখানে গ্লোমেরুলার কজগুলো সিলেক্টিভ হয়ে যাবে, সিলেক্টিভ অ্যালবুমিন হয়ে যাবে। নন সিলেক্টিভ হতে পারে, সিলেক্টিভের মধ্যে কি হচ্ছে মিনিমাল চেঞ্জ ডিজিজ, শুধু একটা টাইপের প্রোটিন। নন সিলেক্টিভ হলে কি হবে, রিফ্লেক্স অল প্লাজমা প্রোটিন রেখে জিএস ফোকাল সেগমেন্টাল গ্লোমেরুলার নেফ্রোসিস, ডায়াবেটিস হতে পারে। টিউবুলার হলে কি হবে, টম হর্সফুল প্রোটিনস বেশি দেখতে পারো, বিটা টু গ্লোমেরুলার হবে, টিউবুলার ইনজুরি হবে, হাইপারটেনশন, ক্রনিক রিনাল ডিজিজ, অ্যাবনর্মাল প্রোটিনস হচ্ছে লাইট চেইন নিতে পারি। এক্সটেরিনাল কজ এগুলো লাইট চেন হতে পারে, প্লাজমা সেল ডিসক্রিজ, ল্যাম্ডা, এগুলো বেশি চলে আসে, ঠিক আছে। উইল নট স্টাডি দিস, দিস ইজ বুলশিট, দিস ইজ বুলশিট। ওকে, মাইক্রোঅ্যালবুমিনুরিয়া হচ্ছে ইউরিন contains less than 30 milligram per day. Micronutrient presence of albumin in urine about greater than 30, less than albumin হচ্ছে এটা, ঠিক আছে। Defined as the persistent elevation of the urinary albumin 30 to 300 in an early in engage possible কি is defined as the persistent elevation of it engages early morning urine sample, এইটা খুব ইম্পর্টেন্ট। এইটা আমি কোথাও মেনশন করিনি কিরকম স্যাম্পল নিতে হবে, স্যাম্পলটা শুড বি মেনশনড, এখানে লিখিনি, এটা ম্যারোতেই লেখা আছে মোস্ট প্রবাবলি। স্যাম্পলটা যেটা নিতে হবে ওটাই ম্যারোতেই মোস্ট প্রবাবলি সবচেয়ে ভালো লেখা আছে। সেকেন্ড মর্নিং ক্লিন ক্যাশ প্রেফার ফর সিনেমাসে, ম্যারোতে লিখে রেখে দিই। Who the fuck is the pen? Open for আগে এখানে আপডেট করে দেবো, বাট ঠিক আছে, আগে এখানে পড়ে নিয়ে এটা, তারপর আমি আপডেট করবো। Genetic labs, the presence of albumin is a sign of glomerular abnormality. So because conventional lipsticks cannot identify this. Acha, conventional lipstick cannot detect. That's a significant sign. It's a sign of glomerular abnormality. Sign of glomerular abnormality. Massively. এই হচ্ছে ছোটখাটো জিনিসগুলো বেসিক্যালি, যে কেন আমি করবো জিনিসটা, ডায়াবেটিস মাইক্রোঅ্যালবুমিন আর্লি ইন্ডিকেটর অফ গ্লোমেরুলার ডিজিজ, এই ছোট ছোট জিনিসপত্রগুলো অ্যাকচুয়ালি লাগবে। Early indicator of glomerular disease in diabetes mellitus, microalbumin is evaluated predictor in diabetes patient, microalbumin increased cardiovascular. Not very I can just make it up in the hypertension, microalbumin essential hypertension, cardiovascular morbidity, mortality, normotensive হলে কি হবে, risk marker for presence of cardio predicts progression of nephropathy, atherosclerosis. আচ্ছা, ট্রিটমেন্ট কি হবে, মাইক্রোঅ্যালবুমিন is reduced with excessive reduction of blood pressure, aggressive reduction of blood pressure করতে হবে। control of diabetes mellitus, AC inhibitors দিয়ে করতে হবে, blood pressure maintain at or below 130 millimeters Hg. Albumin creatine ratio, this is very important. Albumin, creatine. I should mark it in. I don't know. Albumin, creatine in ratio. It's damn horse for protein. The 24 hour most precise was the most precise. However, it is perfect convenient to serum and the ACR of 2.5 to 20 30 to 30 respectively. अच्छा adequacy मिले जाए मोटामोटी अच्छा KDGO A1 A2 A31 अच्छा nephrotic range protein rate trace to ACR अच्छा I don't think this is important. Read KDGO separately. Normal protein in urine. Oh, so no protein or chicken is the rate of 25 milligram per day. Function is not known. Protein function not known. Why? Function is not known. Probably it is some immunomodulated activity against UTI, consequence of urine cast. Okay, all types of urine cast. The part of the pathogenesis of cast there doesn't matter. Protein and hematuria. Hematuria is gross visible on gross examination as bloody urine. এটা আসবে, এটা পর কোনো কোনো কোশ্চেন ঠিকই আসবে। or hematuria, bloody urine, macroscopic hematuria, or detected chemical testing, microscoping, 3 or more RBCs per high powered field. Okay, we got it. Side of bleeding. Okay, features mentioned in table 10.8. Let's do this like this. Localize by listing. Urethra blood is seen at the start of voiding urine. Start of voiding urine. Bladder হলে diffusely present. Glomerular হলে তো আছেই, cola colored urine তো we know very well. Casts, dysmorphic erythrocytes, acanthocytes. Basically damaged RBC যা হয়। Renal pelvis and lower pink or red color urine, prostate or bladder base only, bloody only the base. At end of maturation, pink. Lower tract isomorphic lower tract হলো isomorphic আর urinary bladder urethra তো হলো না, urinary bladder না, glomerular হচ্ছে diffused আর এখানে lower tract হচ্ছে isomorphic। ঠিক আছে, মাইক্রোস্কোপিক ক্লটস ওটা ছাড় হবে না। কজেস অফ পেইনলেস হিমাচুরিয়া। ও ফাক, এটা হাউ ডু আই মিস দিস ম্যান? কজেস অফ পেইনলেস হিমাচুরিয়া। ও ম্যান, এটা কমন কোয়েশ্চেন ভাই। ডিডি বলো। চলো, কিডনি, glomerulonephritis, IgA nephropathy, pyelonephritis, acute severe pyelonephritis, papillary necrosis, most common in diabetes, sickle cell anemia, tumors, relatives, carcinoma, benign familial hematuria, microscopic polyangiitis, granulomatosis, ureter, neoplasms, bladder neoplasms, trauma, schistosomiasis. Oh my god, prostatitis, neoplasm, urethra, trauma. अच्छा, blood glucose varies within 7 to 120 mg per dl. This may increase 120 to 116. Normally all glucose in blood is filtered through glomerulus due to the proximity with the renal threshold is exceeded. The blood glucose will not be reabsorbed into the blood. Estimated in the presence of the detectable amounts in glucose is urine, and urine is termed as glucosuria. Drugs such as glucose and protein SGLT that বেশি তাড়াহুড়ো করছিস। Glucosuria, blood glucose level between 70 to 120. This is main cause. Normally all glucose in the blood is filtered through the proximal tubules. अच्छा, বেকার এটাকে নিয়ে ঘাঁটিয়ে লাভ নেই। অলওয়েজ গ্লাইকোসোডিয়া ড্রাগস জাস্ট blah 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 can cause এটাই মেইন ইম্পর্টেন্ট। SGLT2 inhibitors, diabetes, FSGS, proximal RTA can cause glycosuria. So the bacterial disease take nitrite from the reduction of urinary nitrate products by bacteria. It is also a leukocyte esterase and then specific neutrophils. Leukocyte esterase secreted from neutrophils in bacterial species. Okay, I'll just when I'll be taking a break, I'll be taking a break during my break time. Okay, then I'll be looking at the chats if there are any, of course. Okay, so nitrite positive indicate bacteria microscopy. Let's see what is the microscopy. How many pages are there to read in this? Okay, 4 more pages. Let's go. Let's do it fast. Okay, you're not wasting a lot of time. Microscopy should be the red pen. What is the red pen? Microscopy. Okay, what do we see in microscopy? We see cells. We see cells. We see. Okay, evaluation of hematuria. Oh, okay. Hmm. Okay, but that's not part of it, right? So casts are under microscopy. Yeah, casts are under microscopy. But why is this shit over here? Doesn't make any sense. Okay, whatever. Just read on. They're expressed in cells per high power field. So there are red blood cells. Red blood cells more than 3 per high power field is enough. Urine indicates bleeding at any point in the urinary system. Dysmorphic okay, urine cells with protrusions or dysmorphic. RBC dysmorphic means it's further higher up in the urinary tract. White blood cells. White blood cells key হয় white blood cells increase pyuria. It's indicative of inflammation. The diagnosis accompanied with leukocyte casts. Okay, okay. Inflammatory reaction indicator UTI, stones, tubointestinal nephritis. There are a lot of things which papillary necrosis, tuberculosis, interstitial cystitis. All of these will present with WBCs, which is more than 5 per high power field. 5 per high power field is called as WBC, which is really a high boundary considering. Okay. When accompanied by leukocyte epithelial gas is called to be of renal origin. Patient's evaluation of hematuria. This is actually going to be a separate topic, man. Why is it under? Also continue on 851. Also continued on A851. Continuation of hematuria, because you should write all of these in the same setting, like patient's evaluation of hematuria, investigations. Morphology of RBCs, morphology of RBCs, economic, microscopic even cytology, malignant cells, smoking. Okay, so you're going for cytology, morphology, RFTs, blood platelets, platelet count, anticoagulation study, of course, to and radiology, understand kidneys, ureters, bladder, prostate, CT, MRI, okay, cystoscope. Okay, casts are one of the organized elements which are found in the kidney, is indicator of it. Okay, the organized elements found only in the kidney, which are indicative of a renal disease, but you can have casts without renal disease probably also. Cylindrical body form of Tam horsefall protein, solidification of Tam horsefall protein. These are distal secretion forms of fibrinogen. Okay, now read this shit up. Let's do it fast. We don't have a lot of time. DD. Oh, the exam day is going to be very difficult, man. Island cast, non-specific. present in the normal urine, acute glomerulonephritis, chronic glomerulonephritis, fever. Okay, non-specific. Iron cast and the significance. Okay, iron cast, non-specific, present in normal urine, acute glomerulonephritis, non-specific. I think that's important. Non-specific normal urine. बाकी rest of the things you can see, waxy cast, end stage kidney disease, amyloidosis. I think that was not very important. RBC cars always indicate renal disease. Always they do. Lupus nephritis, good pasture syndrome, severe bacterial. AC. Oh man, good pasture. Good pasture is important. Lupus, acute. These are important. Renal infection, I don't care. Fever, congestive heart failure. Okay, I'll give you that. End stage kidney disease, chronic advanced. Okay, I'll give you, but I won't remember this probably. Fever, I might remember. I'm not very sure about it. Leukocyte, acute paranephritis, I remember. Glomerulonephritis, I remember. Interstitial, I remember. Epithelial cast, will the epithelial is sloughing off. Mm. Drug possible, tubular interstitial nephritis possible, transplantation not, I'll remember. Acute tubular necrosis or injury, I'll remember. Coarsely granular or finely granular, okay. Granular cast basically. Tubular damage, nephritis. Tubular damage, nephritis, renal failure. I remember. Fatty cast. Okay, nephrotic syndrome. I remember. Fabry's disease. I remember. What is Fabry's disease? By the way, let's just look it up. And let's just also see if it's going on properly. Okay. Caramel tax. Bro, what is my channel, man? Switch. Not a good medico. Not a good. Not so good. It's live stream happening at all. Yeah, it's yeah, it's the camera quality is not that bad, I think. Yeah, let's block this thing. And what was I searching for? What was Fabry's disease? Let's just look it up in one go. Okay. Disease. We don't have a lot of time. Fabry's disease is, you know, mm, 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 sphingomyelin something problem, that was signs and symptoms. Generalized pain, kidney complications, chronic kidney disease, hearts affect several ways, skin cause, DNA sequence, alpha galactosidase. Deficiency of alpha galactosidase A. This enzyme deficiency results in accumulation of glycogen. A lot of things. Corneal dystrophy, hyperhidrosis, a lot of things basically. As is which enzyme is alpha galactosidase activity and enzymes. Okay, treatment available for Fabry's disease. Okay, agal series, which is basically I think alpha galactosidase alpha. Agal series alpha, yeah. Agal series alpha galactosidase beta. Pegylated pegylated uni alpha galaxy. Yeah, pegylated uni alpha series. Okay, basically alpha galactosidase. Yeah, everything is like pegylated alpha galactosidase and something like that in that order basically. Prognosis, life expectancy. Whoa, that's pretty good. 58.2 is not bad. Okay, epidemiology research should be good. Okay, I've got enough information. I just looked the classification of families, is where it was. Where I found it, I don't. I Fabry's disease, under which set of disorders? Lysosomal storage disorder. So what about the lysosomal? Hmm. Table of lies. So that lysosomal storage disorders. This is too deep. I think this is better. Yeah, I think I was. This is the one I was searching for. Let's just open up in a new window. Open image in a new tab. I think this is the one I was actually looking for. Yeah, Fabry's galactosidase alpha galactosidase A deficiency. Lysosomal type is 1, 2, 3, 4, and okay, there is something of numbering over here. Okay, and okay, alpha galactosidase Fabry's is alpha galactosidase A. Gaucher is beta glucosidase. Gaucher also had, I think, Crumple cells or something. Is so Gaucher cells. What is this? Gaucher. Crumple tissue, crumple paper appearance, something. Histopathology of Gaucher's disease. This is how you delete and study basically. Gaucher cells, yeah. Crumble tissue paper appearance. Let's just look at some of them once. Then we'll understand where's the crumpled tissue paper appearance. I don't find it. These are the ones. I think this is the one with the crumpled tissue paper appearance, if I'm not wrong. I guess so. Yeah, this also says the same thing, wrinkled crumpled tissue paper like appearance. Let's go back and just look at some of the other things which are said over here. What is sheet like? Look at this. Cautious disease. Okay, now let's just read this thing through. Cautious beta glucosidase, glucosidase, finger minus finger, dynamics. GM1 is again beta glucosidase. I think something is wrong over here. MPS1. Mucopolysaccharidosis type 1 is MPS1, MPS2. Where are the rest of the things, man? I think this is not the right table. Glycogen storage disorders. Is this the right one? Open image in new tab. Let's see. Oh man, this is pathetic. No, this is not right. This is also not right. Where is that? These are not right. These can be right. Yeah, this is the right one. Type 1, Von Gierke. Type 2, Pompey. Type 3, Cories. Type 4, Corey Anderson. Type 5, McArdle. Type 4, Hurst. Type 7, Tauri. This is the mucopolysaccharidosis, not GST. This is GST. I am a bit confused actually right now. I think something is wrong over here. Okay, let's just not waste too much of time. Okay, where did we start from? We started what was Fabry's disease basically. Yeah, it was alpha galactosidase beta deficiency, if I'm not wrong. Okay, so let's get back to studying. Okay, so where were we? Here. Telescope, I don't care. Bacterial cast. Acute intestinal renal infection broadcasts. Progressive renal failure with compensatory. I don't think I'll remember this shit. Okay, crystals. Crystals are very important. Not these kind of crystals. Fuck. Calcium oxalate is important. Normal large number, basically hexagonal crystals. Hmm. This crystals thing is better written in okay, calcium triphosphate crystals. These are important. These are important. This is actually important. Crystals are actually better given, I think, marrow. So let's read from marrow. I wasted 30 minutes on a single fucking question, man. But at least I've covered the topic end to end, probably. Just read it once. I think we can go back to that frame. We'll go back to solving questions in a bit. Right, during examination from here to here. Yeah. And along with that, what did I, yeah, there is flag stored. Second morning, clean catch sample for discarded because the mill is the particle because of the night and sample weight empty the drainage bag. Urine sample should be analyzed 2 to 4 hours. Room temperature can be assessed within 12 hours if it is kept at 2 to 8 degrees Celsius. Assessment of urine pH should be done immediately. Lot of the urine, blah 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 blah. Oh my god, there's a lot. Casts in urine, I think it should be read because of collection, casts, and crystals from here because it's honestly it's better in marrow. Formed in distal convoluted tubal matrix. It is not almost with their this course and diseases cast course. Mm-hmm. Find a cast integrated renal disease. Again, start reading again from here just to be double sure about whether we are not doing it incorrectly. Okay. Um, Cast significant Vaxicast there is a sharp indentation is indicative of CKD. Okay, Vaxicast is indicative of CKD. The Marrow is such a good app actually. It's like the notes is so well structured. Sometimes I'm really amazed. Found in the distal convoluted well matrix time hospital put is okay. It's because they're going to normal. It's a granular cast. Core granular cast no significance. Final cast. Instead, look at over here. It was like the fourth granular cast and final granular cast, they just clubbed it in the same thing. The thing is, fourth granular cast has really no significance. No significance. And this is this which has all the significance. Okay, renal epithelial cast which are larger than the size of the WBC is specific for ET and AIN, muddy brown epithelial cast. Okay. The WBC partially UTI one of nephrotic acid cast second by it is material the IgN. Okay, broadcast. Advanced CKD. Okay, I was just thinking fatty cast. Nephrotic. Unbelievable metal cross appearance. Metal cross appearance. Bilirubin cast yellow because of hyperbilirubin. Man, it just so this is better in marrow. Just read and this is just so much better. Fatty cast. See in Fabris. Yes, it was also written more Fabris. Okay, use to count fracture cast not seen in urine, just cause myeloma. Okay, fracture cast not seen in urine, pathological finding seen in myeloma. Cast seen in urine, okay, uric acid crystal, rhomboid, yeah, calcium dioxide, envelope shaped. That is the thing which was lacking over. You write a book and it's and even then it's still not complete. That's so frustrating, man. Calcium oxalate dihydrate, it's envelope shaped crystals, which is with this one envelope shaped crystals. It's like envelope shaped over here. And if you can see that, I don't care actually. And the calcium monohydrate is dumbbell shaped, it's like proper dumbbell shaped. I think that, yeah, dumbbell shaped. This is basically dumbbell shaped. Yeah. Okay. Star-shaped is calcium phosphate, coffin lid is true white, coffin lid appearance, true white, cholesterol crystals and nephrotic syndrome, hexagonal crystal is cystinosis, Bloomberg it is amoxicillin, star-shaped is calcium phosphate, this is calcium phosphate, star-shaped, coffin lid is true white, calcium is true white stones, magnesium ammonium phosphate, sorry, it's magnesium ammonium phosphate, true white crystals, cholesterol crystals are seen in nephrotic syndrome, and hexagonal cystinosis. I don't care about that. Okay, so let's move on. I think this topic is very much well done. Let's move on to the next few things. Let's go on to writing answers. Okay, I think this is done pretty well. Hmm. Hmm. I've included that. Okay, now let's get on the questions. Okay, let's get on the next question. Okay, newer diagnostic therapeutic. Okay, newer diagnostic approach and therapeutic options for MDR TB has emerged. Okay, so let's just check if we have anything in the question, then we'll be from there. If there isn't any, then we'll move on to other options, infection including HIV, HPV. Okay, I frankly do not have any idea what they're talking about. Respiratory system, you should find out. Allergic pneumonia. Let's see. Yeah, TB. MDR TB dot tuberculosis. Let's just read it up. 57. This really read a lot, man. It's really reading a lot. But at least I'm studying right now. I'm feeling good that I'm studying. Otherwise, I just feel depressed or sleep. No, these are not. Yes, what is the new updates in TV? How do I find this? No, it's not in this. Let's find it. Okay, let's find this book. It's on the respiratory medicine or something. It feels so right. Gastroenterology, HIV, TB should be something like that. Tuberculosis is very weird thing, man. Pokes its nose into literally everywhere. Bacterial infections. Tell me it's tuberculosis. Where the fuck is tuberculosis? There is no tuberculosis. What the hell, man? Okay, extrapulmonary tuberculosis, extrapulmonary. Okay, there we find is 229 to 250, man. 30 pages of. Wow, that's a lot to study actually. Oh, 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 oh. That's pretty difficult. It says only the newer diagnostic approach and therapeutic options for MDR-TB. Only for MDR-TB and only the new options which have emerged. So, what are the diagnostic modalities for MDR-TB? Like, if we look at that, there's NTP guidelines. There should be something. Okay, I get it, but okay, huh? Mm, mm. This is not what I wanted. Oh man, okay. I think Nikshay portal has. This looks good. Person living with HIV, HIV, PMDT, CVNAT, you go directly for CVNAT and here which is smear examination of chest X-ray, and depending on that you do the CVNAT. Hmm. I think this, yeah, I know it's people living with HIV. Okay, many people might not. Okay, I get it, but okay, wow. This is the NTP guideline, right? Wow, this is the simplest I've seen, man. Wait, let me just read it from here only. This is I'm being honest. This is the simplest I've seen any TB regimen. This is like the NTP guideline. This is the best guidelines that is possible. How much time do I have? I have 10 minutes left. Okay, let's finish this paper. How many questions are there? Oh my god, 2 questions. Okay, we'll cover it. Let's see. Smear examination, chest X-ray, smear positive, chest X-ray, positive, smear TB. Smear positive, but TB not. Smear positive, chest X-ray suggestive. Okay, this you can go directly to microbiology confirmed TB because smear is suggestive of TB. And this is also smear positive, you can diagnose microbiology. If it doesn't happen, but okay, they say you're not going over here, but people living with your planning is wrong, man. You could have just put people living with HIV over here and then drawn the arrow. It would have made us very easy for us. Piece of, I don't know, but genius people. I mean, you guys got this correct. Just X-ray over here and smear not available. Smear not available. Clinical suspicion high. Then also you do CBNet. Whatever you think, do CBNet. MTB detected, defunct is sensitive, indeterminate resistance. Sensitive, you call it microbiology confirmed TB. Indeterminate, repeat second sample. Intermediate on second sample, flesh sample for liquid culture or line performance as a defunct is resistant. Refer to management, defunct is resistance. MTB. They consider alternate diagnosis, refer to specialist. Okay. Okay. Hmm. Okay. If MTB detected, then all this. If not detected, if pediatrics patient are detected, okay. If pediatric patient, how do you what's your selection criteria? Persistent cough greater than 2 weeks, not without a known cause, unremitting cough for greater than 2 weeks, what weight loss of 5 months in 3 months, or no weight loss weight in the past 3 months. Okay, no weight gain in the past 3 months, greater than 2 weeks of persistent fever, unremitting fever for the last 2 weeks, without any known cause. Okay, first you do CBNAT. First you come, you do CBNAT. If CBNAT is not readily available, smear microscopy should go on, but CBNAT on sputum. In microbiology TB detected, microbiology confirmed TB. Okay, if CBNAT is not there, if NTB is not there, or sputum is not available, then X-ray, chest, and what the fuck is TST? Oh, tuberculin skin test. Oh man, I'm so getting bad. Okay, chest X-ray, NS shadow, non-specific shadows. Okay, chest X-ray highly suggestive. Do gastric aspirate. Why? Because they take in the sputum. Okay, they swallow their own sputum, which was actually filled with TB. So since you couldn't get sputum or something, just take the gastric aspirate, induce sputum for CBNet. If you can induce sputum, it's good. But if you, I don't think you can. So do the gastric aspirate. If it's positive, then it's again microbiology confirms TB. It's negative, then no other likely diagnosis. Oh, if there is no other likely diagnosis, then consider it clinically diagnosed TB. Okay, this area is done on chest X-ray, highly suggestive. If chest X-ray shows non-specific shadows and tuberculin skin test is negative, then give a course of antibiotics. If you see persistent shadows and symptoms, do whatever the fuck you feel like. If chest X-ray normal is and tuberculin skin test is positive, then evaluate for extrapulmonary tuberculosis or refer to the expert. Chest X-ray positive and then why is it okay, it's extrapulmonary because it didn't come on the CBNAT, right? And if chest X-ray is normal and tuberculin skin test, then look for alternate diagnosis. Do gastric aspirate, everything goes for the gastric aspirate sputum. And if it is negative, refer to expert and work off do something else. Okay, if presumptive extrapulmonary tuberculosis, appropriate specimen from site be it lymph node or be it available. If it's available, then do the CBNAT from that side. Microartery were detected or not. If it's detected, do the same thing. If it's sensitive, indeterminate resistance. If it's sensitive, then we could do a microbiology confirmed mixed abnormal TB. If it's indeterminate, then repeat CBNAT for the flesh line. If it's still indeterminate, then do the take a on say the same experiment, do fresh sample for liquid performance assay or liquid culture, whatever you feel like. And if CBNAT is not doable, then again do the line performance assay. It's just doing the same thing. But if it's still negative and high clinical suspicion, then use other diagnosis tools or call it clinically diagnosed TB. And yeah, this is what it is. Presumptive TB, presumptive TB to smear, presumptive TB. I don't think this is really required. This thing they ask. Oh my god, this thing they ask. HRZE, HRE, in what number of tablets do you give them? Oh, drug dosage according to weight category. This is pediatrics and this is adult. For adult, how do you divide? And for okay, for adult, HRZE, HRE. HRZE 6 months and HRE, I think I'm very stupid, man. This is very bad, man. You should remember, this should be on the top of your fingertips, man. This is very bad. This is very bad. How can you forget this thing? Okay, HRZD 2 months and HRE is 4 months. Very bad, man. Pathetic. Pathetic. You could be ashamed of yourself. HRZD 2 months, HRE 4 months. Okay, and injections streptomycin when it is used. For 25 to 35, 25, 35, 35, 50. Okay, 25, a gap of 10, 15, 15, 50. 10, 15, 20, 10, 15, 15. Who comes up with these things, man? 2, 3, 4, 5, 6. Okay. HRZD, HRD. 2, 3, 4, 5, 6. 10. You start at 25. If you're an adult at less than 25 years of 25 kgs of weight, I don't really have zero idea what to do. Style. This is very difficult. HRZ comes in one pack and E comes in another. Okay, so they have to take 2 tablets. H, and these are daily regimens. Okay, HRZ daily, it's daily for. Oh, I've forgotten actually so much of these things. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2. Everything is 1, 2, 3, 4. Okay, everything is 1, 2, 3, 4. So 4, 3, 3 gap, 3 gap, 3 gap, 3 gap, 3 gap, 3, 3, 3, 3. You do then 8. I'll take it as 10. 3, 3, 3, 10, 5, 10. Who is coming up with this? Why? What is this A thing? Okay, 2 plus 2 into adult or something. I don't know. Oh, come on. Okay, I'm gonna write up till only here. Okay. 1, 2, 3, 4, 1, 2, 3, 4. And HRZE, HRE. 50, 75, 15. And here it's 75, 150, 400, 275. 75, 150, 400, 275. Okay, how much time do I left? 2 minutes only. Oh, man. Newer anti-TB drug, bedaquiline and use as only bedaquiline and NTP algorithm for TPT. Yeah, there aren't really much new as such. Like, what do I write? Newer anti-TB drugs. I think there aren't there newer diagnostic approach and therapeutic options for MDR TB. There, yeah, this is for MDR. This is for MDR. This is for MDR. This is the newer drug which I have seen, and they're asking for newer diagnostic modalities. Okay. Investigations. Chess City. Are they talking about Chess City? I can't really understand. What is the new diagnostic modality? Are they talking about CVNet? Is CVNet? CVNet is new, but I don't know when they have made the question. Like, what are they calling of it as new? Like everything which is older than 1 day is old for me. I don't care. Most positive sufficient. I think they're talking about the CVNet only. Like I know CVNet is, yeah, it's a new test, but I think they're talking about this only. I really ain't finding anything else over here, to be honest. I think they should be talking about this. I'll check in Marrow once, but although I'm not very sure of this answer. Diagnosis of tuberculosis. What are the new modalities? Let's see. This is 18. Okay, I'll relax, but I'm a bit confused as to what I should do. I don't think there are any chats, but should I look at them? There aren't supposed to be any. Ooh. Yeah, there aren't any chats. Yeah, I'll do one thing. I'll go and get some oranges. It's not an orange actually. Wheat. This doesn't look like it's gonna survive a few more days. How much time do I have left? Okay, 6 minutes. Not bad. 6 minutes is enough for me. Yeah. Oh, you see me skills. The perfect slice. It won't work. Good enough. Moments. Okay. Three minutes. Hey yo, stand up. Can't stand up for yourself. You would always be neglected by society, right? Sometimes I just get a bit philosophical. Nothing to worry about. Yeah, it's fine. Oh, this completely plays itself out. It's okay. How much time do we have? 2 minutes 36. Not bad. The skin of this is so weak. It can't even handle a knife going through. Yeah. So is my skin weak? It also can't handle a knife going through it. I'm actually learning slowly how to stay in hostel, how to like lead a healthy life. Like I've stayed in hostel for around 3 years right now, but I never really knew how to stay live a healthy life. Like, slowly. Maybe this exam, which is I have my semesters a few days ahead. will slowly teach me how to live a healthy life while staying in hostel. So let's see. It's always a journey, man. The destination is never the what should I say? Never the motto of going on a trip. The motto of going on a trip is to enjoy the journey. Because see, everybody reaches the same spots, right? But you don't talk about the spots unless it's of course something like Pahalgaon or something. Everybody talks about the journey that they had, the problems that we they face, and that's why I recommend never travel to some place on an airplane or if you can travel by train because that's always more exciting. If you can travel by car to a place, for example, always try to do it. Okay, always try to travel by car if you can. Like that's always more exciting because you have stories, you have mess ups, you have stories, and then you have things to tell to people. Otherwise, you really have nothing to tell to people. Okay, so we'll be getting to our study mode in a few seconds. So let me just clean it up. I'll be back in no time. I'm gonna be back in 30 seconds. Okay, so the time has already started, right? Uh, let's just do one thing. I think this is what they're actually looking for. Okay, infections in nature, things are undermined. So let's do one thing. I'll just check what are the latest updates in TB MDR. Yeah, they're talking about the gene expert and TrueNet only. Um, yeah, so I think if it's gene expert and TrueNet, I have my answer. I was just thinking it way too much. Okay, these are the newer anti-TB drugs. Okay, so we'll get to that, but let's just first study. Okay, let's first study and then we'll see. This is what CNMC 8. Your beta lactams. Okay, this won't work. Let's go on with this one. Newer anti-TB drugs. Yeah, beta lactams, bedaquiline, delamanid, okay, benzothiazines. Yeah. Yeah. Okay, beta lactams, imipenem. Used rarely. Beta lactams. Okay, so it's basically everything of what we know of the new regimen. It seems like that. Beta lactams, linezolid, clofazimine, clarithromycin, dapsone, metronidazole. Yeah, all of these things. Beta-quiolin targets proton pump of ATPase. Mm-hmm. Delamide and pretominids are nitroimidazoles. Okay. Still on clinical trials, but I think we can consider it because these guys are anyways late. Drugs hit the market and they're still writing the books. Just one thing, we'll look at the marrow notes if it's anything over there. Okay, diagnosis of tuberculosis. It's 9 pages. We can read it through. It's not going to take long. Drug sensitivity, tuberculosis, drug sensitive, drug resistance. Okay. And resistance against fields of drugs. Okay. So on polydrug resistance, resistance to INH and other first line drugs. Okay, so monodrug resistance, resistance to INH alone, and this is polydrug resistance is INH and other first line drugs other than rifampicin. Because if it's rifampicin and ancillin, it becomes multi-drug resistance to tuberculosis. Okay, first line drugs are HRZ basically, isoniazid, rifampicin, pioneer. Diagnosis: sputum smear with acid phase sensitivity 50% and hence the chance of false negative sent to the 4,000 fields are to examined before reporting negative. 1,000 per ml if the bacterial load is it's called as a positive report. Yield is increased using hypertonic saline before collection of sputum and bronchial washings after bronchoscopy. Odomin, rhodomin staining and fluoroscopy seen are confirmation by culture 4 to 8 weeks tended to middle vasculitis, middle broth 3 to 4 liquid culture or HPLC 8 to 14 days backtech or MGIT is used. Phenotypic DS drug sensitivity testing is done in 1 to 2 weeks. Anticipating of smear is to 0 record number exact 1 plus 2 plus 3 plus. Okay, 1 plus 2 plus 3 plus. Okay, record 1 to 9 is record exact number seen in field. Okay, the 10 to 99 is grading 1 plus per 100 actually per 100 oil per field is scanty per 1 to 10 per oil emission field is 2 plus. Okay, 1 to 10 per oil emission field is 2 plus. You get that thing in mind. This is your like keystone. Okay, what is the LED fluoroscopy microscopy have done? Increase in performance, increase in lifetime, reduces initial operating cost, maintain no need for darkroom stains, rhodomin smear culture culture requires minimum of 10 to 100 viable bacilli. Cultured sputum may be positive treatment started. Sputum may be negative, maybe extrapulmonary tuberculosis. Sent to sputum culture LJ medium. Okay, culture is sputum culture. Treatment started. Sputum negative, maybe extrapulmonary TB. Sent to sputum culture LJ medium for 6 to 8 weeks. Empirical treatment started. Automatic culture medium MGIT and 96 results within 1 to 2 weeks. Can check for drops in immediate testing. MGIT medium is position obtained at the end of 10 to 12 days. MGIT is used a rapid method for detection of drugs. Drug resistant strains of MTB directly from acid fast positive samples as it is cheaper. No problem of radioactive waste disposal as the advantage of a backtech. Gene expert CBNAT real time PCR nuclear semi-cold full automated taking 1 hour 5 minutes. Samples are sputum, lymph node, gastric aspirate, pleural aspirate. Only sample can't be used. Blood, stool, urine can't be used. What are the samples which can be used? Sputum, lymph node, gastric aspirate, pleural aspirate. Pleural sufficient results positive and negative with 98% sensitivity. Sputum and okay, let me just take one of these things. Hmm. They've made this thing more complicated, man. By the way, I must say that these oranges which I have got are really great, man. These oranges, like beautiful. These oranges are, yeah, wonderful. Like, sorry, these are not oranges. These are actually citrus. Yeah, useful in low prevalence countries. False negative energy circulates immunosuppression. Acute viral infections, measles in the period. I do. Cancer reactivation, etanercept and infliximab adalimumab. Infliximab and adalimumab. Infliximab is what? Oh man, I forgot. We'll see it later. Infliximab. Yeah. It's very uncommon in children. Got it. Let's just wash my hands and then I come back. The hands properly. Diary में रहकर फिर मेरे पास participate. Do none about it. Can't do none about it. Now take over mama. Can't do none about it. What I can do is विषय खत्म मेरे साथ मेरा मुंह पूरा विषय खत्म नाम सुजल का ब्रूटल विषय खत्म मेरे हाथ में पूरा विषय खत्म चल मामा करो तेरा विषय खत्म मेरे हाथ नीचे टांग ऊपर विषय खत्म चल नाम सुजल का ब्रूटल विषय खत्म मेरे हाथ नीचे टांग ऊपर विषय खत्म चल. Okay, I need to one thing. Yeah, it's the second promoter actually. Okay, glycogen storage. So out NTP out this out that out. Let's just write it down. Where is it? Infectious and HIV. Huh? It's not my thing. Infections and HIV. A tropical infection zone. Nah. Actually, this comes under a bit under respi also actually. Okay, I'll including under tropical diseases. No, no. Otherwise, I can't include this thing. Isha would be looking. I believe Isha has written the right answer to it, but again, like, it's not like I don't trust her. She is a very good student, so she has probably got the correct answer. But again, I'm studying it also. And it's preparation of for me of the exam only. Let's put a double question mark over here. Diagnostic approach would be. I think it's safe to write about gene expert and these things over here. I don't think gene expert and NP I think are the best over here. It's only 4 marks, so why are you looking at in the treatment of TB? Find it out. It's something else, nah. Should be in the diagnosis of TB. It's I think it's gene expert only. Gene expert and one thing there. Gene expert CB NAT MGIT 960. Or I mean, I think it should be. What about HPLC? HPLC Techs. Lipoarabdomanin. Hypoalbuminan. 4. I don't know how old is LP. I really have no idea. 277 under scroll 1. This is pulmonary TB. They give the same flowchart over here, so can't really fault them. Mhm. There are actually some more things. No, drug resistance TB only this much only. Anti-drug MDR TB. They didn't say it about specifically, but I'm a bit confused. Okay, let's move on. You can't just stay on with one question. It's going to take an eternity. Atrial tachycardia is multifactorial. This, I think, it's a very sweet answer over here. Not wrong. This 10 years has a very good answer. Atrial tachycardia being multifactorial. Atrial fibrillation and atrial tachycardia. Oh. Ha. Dude giving atrial tachycardia. Anticoagulant different types. Okay, let's look at 5, 6, 7. 7. Atrial fibrillation and different types of tachycardia. Uh-huh. Okay, let's look at the books, for example. Atrial tachycardia. Wow. Cardiac arrhythmias. This should be a good starting point. 124. Let's see. Hmm. Supraventricular ectopics. I think there should be a well specifically says tachycardia. Hmm. Hmm. The book apparently doesn't have a very good enough calls. I looked for ventricular fibrillation and ventricular tachycardia and club them up. It's bad. Bro, what is this? Adam Stokes attack. Wow. Etiology, ventricular systole. Prodrome prison. I read it about it once. I forgot. Yeah, this is a nice thing. Sudden loss of consciousness unrelated to posture without convulsions due to disorder of heart. Adam Stokes attack. Yeah, Morbid's type 2. Yeah, you're not gonna find it after this. What are you going to do? Torsilis D point. This you said about ventricular tachycardia is not atrial tachycardia. Atrial tachycardia is of six sinus rhythm, PSVT, and I think with the sinus tachycardia, supraventricular tachycardia. Premature ventricular complex. I don't think this is right. Yeah, without precision. They like by Gemini. Institute. It has not. So basically, it says atrial tachycardia. Doesn't say atrial tachyarrhythmia. I think the answer would go on along in this direction. It's not atrial tachycardia. It's just atrial arrhythmia. I think so. Like that should be the modality of answering this question. So tachycardia is multifactorial. Yeah. Who came up with this idea of attend any five, man? What the? No, not your bitch. CVS is way up. Cardiology, yeah. It's first question, then the second question. Okay, now it's the fifth question. Sinus tachy. Why do you need to have arrhythmias? Like, yeah, tachyarrhythmia is tachycardia is an arrhythmia, na? Yeah, tachycardia is an arrhythmia. Mm, yeah, tachyarrhythmia is a type of arrhythmia. Tachycardia. Oh, all factors are over here. Atrial tachycardia. Wait, what's the difference between atrial tachycardia and supraventricular tachycardia? It says tachycardia, it does not say fibrillation. So, what's the definition of atrial tachycardia? Defined as the heart rate greater than 100. So, it can be anything like, yeah, atrial flutter, atrial tachycardia, multifocal atrial all of them are. Yeah, but there isn't any cause that you have written. You stupid piece of. Yeah, you wrote no cause. You bingo. Yeah, rose fluttered, but there's no cause. Nice fibrillation. I have causes of flutter. There isn't much wherever I'm reading. Huh. Wow, and I have 40 minutes left already. Oh my god. Two questions took me such a long. I think we'll start with the process of atrial fibrillation and then leave it upon Sir to find out the rest. Yes. Because they say it's multifactorial. I just put in the process of fibrillation and call it multifactorial. What else do I do? Where's the pen? How did I get lost in the pen over here? The hell? I need a ball, but it's there. What are the other causes of tachycardia? Sinus tachycardia, I guess. Q5. And then we have sinus tachy, I guess. Sinus tachy, PSVT. These are all good causes, man. Brugada syndrome. Yeah, it's hard design. Oh, Sandel carditis. Yeah, yeah. No, I just want sinus tachycardia. AFib, AFLR. It's not that big actually, that's the problem. Why do you not have sinus tachycardia? Okay, sinus tachycardia. You don't have reasoning of sinus tachycardia? What the bullshit is this, man? You don't have reasoning of sinus tachycardia. You should be ashamed of yourself, man. You're writing a book and oh no, there is sinus. I'm just hating on this. Sorry, bro. Sorry. Because this is. Where is the pen? Where is the pen, you stupid? Again, you lost it, man. There should be again some cause. It's not like. That's because of AV nodal re-entry phenomenon, PSVT or FVT, whatever thing you're talking about, there has to be some cause. It's not like it's happening just like that. There's exercise, emotional, pregnancy, pathological include anemia. Anemia causes sinus tachycardia. That's what I said. Palpitation, thyrotoxic causes anxiety, thyrotoxic anxiety, fever, heart failure, pheochromocytoma. Exactly the things which I wrote. Yeah, I was not wrong in that answer actually. I was correct. Yeah, but why does a PSVT happen? For example, why does AVRNT happen? Paroxysmal supraventricular tachycardia. Where is it? One fine PSVT over here. Dorsal is defined. Ventricular tachycardia should have PSVT somewhere. It seems like there is PSVT. Paroxysmal supraventricular tachycardia. Where is it? Please have it over here. PSVT. I don't think you'll have it, but it's mainly I think re-entry pathways. That's the reasoning of PSVT. If I'm not wrong. Or there are separately discharging, yeah, treatment of PSVD types. There has to be a reason. Why is there no reason regarding PSVD? I don't get it. You guys are running this without reasons. PSVD doesn't have any reason, man. I'm a puke right now. This book might die. This book is good, but generally does not contain what I need. That's what makes me angry on this book. So I'm pretty sure I'll still not get what I need. Okay, I'm go and just turning the pages to be disappointed again. I'm pretty sure of that. Cardiac arrhythmias 408. Sinus arrhythmia, sinus tachy. Right. Okay, AV block. AV block also got sinus tachy. Should be. It's not tachy actually. Mutual ectopic beats, no symptoms. Box 16.0. Associated, sometimes associated with EV block. Mhm. This book does not contain the causes. Atrial fibrillation is a cause. Still better. It has a pathogen, it doesn't have a cause. Like I know it's an extended right atrium, that's the reason. Anything which extends the right atrium will cause it, like rheumatic heart disease, ischemic heart disease, AMI, which cause it to extend. Cardiomyopathy, pericarditis, hydroxydosis, 6 and again, you can put it inside, but mainly it's basically stretching of the atrium. Yeah, there should be a supraventricular tachycardia, nodal reentrant tachycardia. What's the cause of this thing? You write an international book and apparently doesn't have a cause for the question which a university in West Bengal asks. Bullshit. Okay, let's just finish up this paper before it's time. Okay. Vitamin B supplementation not adequate for megaloblastic anemia because it also requires folic acid supplementation. That's the answer in small. Now I don't know what the answer deficiency disorder. I'm pretty sure they're going to something along the lines of what I just said. Cannot be anything else. Yeah, it's just that they did not explain that thing. Yeah, nobody seems to get why I am mad. I think it should be answer should be in hemat. Let's see. Mm-hmm. Not here. We'll have to search in marrow. Ah, and what is this under nutritional disorders? Is it under my topic? Yeah, it's under deficiency, if I'm not wrong. And it also can fall under hemat. Hemat, do I have hemat? I don't have hemat, but it can fall under nutritional deficiency. What was the question which was last right? Oh, AFib causes. Let's look at hemat over here. I think this is a good book. This should have it, at least. Please have it. Macrocytic anemia 736. Please have it. I don't think I have a lot of time left in my hand. 3 minutes, 7:36. Let's get it. What? Bro just wrote it and went away? Just says megaloblastic anemia, nothing else. It doesn't say pernicious anemia. Management of megaloblastic anemia. But may be aggravated, precipitated despite responsive. Now I said this somewhere. It's not written very well over here. Prophylactic folic acid should not be given when planning pregnancy. Okay, let's just rest. Okay. Let's just rest. It's open WhatsApp. I just check out all my messages are okay. Chill. Get a minute tags in the bottom bit. Okay, I can do one thing. I can just find out what the roll numbers are and match it accordingly and then send it. Yeah, I've got a promo. I've got a break time. Copyright strike incoming. Only vitamin B12 supplementation. Okay, let me resume this thing. Yeah. Accumulation of Finally able to complete CNMC. Let's go on to the next papers. I'll go back. I'll put a green on this topic, man. Nice. Put a green on this topic. What happened? Organize. Put a green on this topic. Yeah, let's go for Kuch Bihar. Kuch Bihar has medicine 2 papers. Wow. Is it 2 papers actually? No, it is 1 paper only. Okay. What's Kuch Bihar short form actually? MJ and MCH. Okay. I think this is the fourth Pomodoro I think I'm doing. No, this is the third one. No? Let me just check from where I'm doing when I'm doing this. One, two. This I think this is the third Pomodoro which I'm doing. Yeah. Wait, let me just check in the stream now. If I check in the stream, that would be okay. Not this one. This is 3-4. Let's go to 1 hour ago. 2-4. 26 minutes left. 8 minutes left. The break happened, and then it's 3-4. Yeah, it's 3-4 only. Now let's go to MJ and MCH. Hmm. 30-year-old keep the 5 days, high fever and chill, rusty sputum, chest pain, mild dyspnea. Pneumonia? I think 5 days, high fever with chill. Rusty sputum. What is rusty sputum? I think this is pneumonia. This is respiratory under me. Respiratory under, yeah, no? I can leave this. This looks like acute pneumonia. Let me just try this verify still. What are the things which present with this kind of symptoms? ILD, I don't think will present with this kind of symptoms where it's ILD classification, interstitial pneumonia, and immune. 50 to 70 years. ILD is for 50 to 70 years. This is 30 years, not matching. First of all, most cardinal symptoms: dyspnea and exertion, cough, dry productive with no diurnal symptoms, hemoptysis, very rare fluid, just plain wheeze. Okay, what are the different? What are the most? Why do you think so? Wow. Enumerate the differentials. It's like, okay, how will you investigate and manage the case? I think this is the case of pneumonia. Yeah, UIP is 50 to 70, chronic, usually no etiology, loss of lung architecture, radicular shadows, linear shadows, honeycombing, traction bronchitis is seen, no treatment, no effective treatment, poor prognosis, only disease that presents with UIP is rheumatoid arthritis associated ILD. Rheumatoid associated with UIP may also be seen with smoking associated. Coarse radicular bilateral fibrosis resembling honeycombing. No specific interstitial illness record. This will be 30 to 50-year-old male. Okay, possible. It's to do with CTDS. What is CTDS? Connective tissue disorders. Systemic sclerosis, polymyositis, Sjogren. Not so possible. Okay, I keep it in a definition. Non-specific interstitial pneumonia, right? You keep it in a differential in SIP. Interstitial lung disease in SIP can be of a possibility. HRCT is finding ground loss of receptive and sparing, no hypomelia shadows. But again, you said sputum, fever with chills, sputum. That's most okay. You said fever with chill, right? Rusty sputum can also be like infective causes. You don't even know. Bisucidine phengiomyos. It's okay, young female associated with tuberous sclerosis. Mapping of pyramids. Okay. I mean, I need to read all of this. I've forgotten most of it. Okay, I need to take some days out and read Marrow. Marrow is like 1,200 pages. We take 5 to 6 days to read only. It's 1,206 days. It's 200 pages a day, and still it's going to take 6 days. It's going to take 7 days if taking a 200, 700 a day. Wow, I've already lost 20 minutes of this one. Wonderful. Venous thromboembolism won't present with fever. Eosinophilic lung disease may present with fever. Mhm. Loeffler syndrome. Possible. Type 1 hypersensitivity sensitive leaking migrated clinical feature. Low grade fever. Cough, which is non productive, but here there is productive cough. Wheezing, substandard tightness. Occasional hemoptysis. Do they think there is hemoptysis? No, there's mild dyspnea. Hmm. Can it be hypersensitive? Very unlikely it's going to be aspergillus for pathogen. What are the clinical features? ABP, aspergilloma, angenesis, mucus plugging with hyphae, as allergic bronchopulmonary aspergillosis. Hmm. Bronchial asthma also has to be there. No? History of brownish plugs in sputum. Are you talking about this thing? Culture, asthma exacerbating clear cough, thick brownish mucosal plugs. Doesn't say since when. Hmm. Can be bronchitis. I think so. Yes, this is a visual cycle like anti-inflammatory inflammation, macrophage nuclear destruction of mucosal. This is it comes with chronic cough, not an acute one, right? Diffuse bronchitis. Tract lines diagnosis X-ray. I don't think this is it. I think it's pneumonia. The problem is pneumonia is not very well described to say fusion empyema. What do they? Pneumonia is not in here. I think it's a case of pneumonia if I'm not wrong. I'll leave it for Aisha. Let's see. 45-year-old patient comes at the emergency room in a drowsy state. He's diabetic and has a fever for a few days. Endocrine is, I think, Aisha's thing. Yeah. He's diabetic for a few days. Dehydrated also was a probable diagnosis. Comes up in a drowsy state. He's diabetic. Yeah, I'll leave it on Aisha. What's a confusional state? Opportunistic infection in HIV. Did I do it already? Tropical and HIV. This is my topic actually. Opportunistic infections in HIV. This is how much? So 5 marks answer, right? Um, mm. Hey, oh no, it's infections and HIV. No, I forgot what the syllabus was actually. I think it was infections and HIV, if I'm not wrong. Indo, okay, I forgot to write it. DK and HHS are very common questions. DK, HHS, and DDs. And here it is infection and HIV. It's not tropical and HIV, it's infections and HIV. We should have written this, then this problem wouldn't have happened. Infections and HIV, we're looking for choose in HIV. This might be somewhere, but yeah, let's just look at this. 5 marks answer right. Six. Speed up, no? What's the name of this college? Q306. What happened suddenly, you stupid piece of Q306? And you need to look at the diabetes thing also, okay? Not treat this. Let's check the name of the college once. Uh, it's MJ and MCH. Okay, I don't need to think about that much. It's MJ and MCH. MJ and MCH8. Interesting infections in 8. Okay, let's do it fast. Okay, we're going very slow. Where are my pens? Where are my pens? I think if you could do it with the, what do you call that? Tally with the how much count has decreased and then write it, na? That would have been better most for the infectious diseases. I think there's an HIV 2022. Opportunistic infections. I think there's a separate. Yeah, I think this is better actually. Left for M1479 underscore 245. CD count, nothing else. Everything else is just bullshit over here. Not bullshit, it's wrong to say bullshit, but yeah. And regimen is given by the numero. I'll read that but later. Okay, come on, yaar. You don't have time to waste. Pneumocystis carinii, pneumonia, pneumocystis carinii. Okay. Mm-hmm. Treated by cotrimoxazole. Candidiasis, infection of esophagus, trachea, bronchi, and lung. Fluconazole, coccidioidomycosis cause pneumonia. And what is this thing over here? Okay, it says 600 is lymphadenopathy or thrombocytopenia, 500 is herpes zoster simplex, which is, I don't think is over here. Yeah, it's herpes simplex, right? It's over there. And then it's Kaposi sarcoma at any CD count. And there's oral hairy cell leukemia or TB. Then it's mucocutaneous with the PCP, basically pneumocystis carinii pneumonia. And then it's cryptococcal meningitis at 100 or cerebral toxoplasmosis, primary CNS lymphoma, HIV associated dementia. PMLE, what was PMLE? I forgot PMLE. Got PMLE. Okay, doesn't matter. Move on. And get to the microatomemians intracellular calcicular diseases. Okay. Uh, histoplasmosis treated by histoplasmosis pneumonia, treated by itraconazole, cryptosporidiosis, chronic watery diarrhea, sporiosis, toxoplasmosis, encephalitis, pyrimethamine plus leucovorin, cytomegalovirus, cause pneumonia, chronic herpes simplex, fever, blisters on the mouth or painful ulcers, ranas, bronchitis, pneumonia. Okay, cytomegalovirus treated by acyclovir, toxoplasmosis treated by pyrimethamine and leucovorin, histoplasmosis treated by itraconazole, cryptococcus is treated by fluconazole, same for coccidioidomycosis, same for candidiasis, chronic herpes simplex treated by acyclovir, few blisters around the mouth, painless ulcers around the genitals and anus, bronchitis, pneumonia and esophagitis as in civilian immunocompromised, tuberculosis, microbiome, ABS, ABM complex, azithromycin, or erythromycin should be enough, recurrent salmonellosis, salmonella, nausea, vomiting, diarrhea, septicemia. Prevention: take heart properly to keep CD4 cell count greater than 400 per cubic millimeter. Yeah, you should use condoms consistently. Prevent sexual violence. Don't consume certain undercooked, under eggs, and pasteurized milk. Don't drink untreated water. Stay away from litter, saliva of pests. Use chemotherapy if CD count is significantly. Vaccination in Hep A, Hep B, Hep HPV, and influenza. Okay, let's look at a heart regimen over here. If we put what is the heart regimen? Let's read it. Where has it gone? Why is it? Let's look at the heart regimen. Actually, oh yeah, let's look at the heart regimen. Hmm. Okay, reverse nuclear. Okay, nucleotide reverse transcriptase inhibitors in plus NRTI plus integrase inhibitor. There has been reverse nucleotide transcriptase inhibitor, nucleotide reverse transcript NRTI. That's basically NRTI. Okay, nucleotide reverse transcript. There's a nucleoside reverse transcriptase integrase inhibitor. So TED regimen: tenofovir disoproxil plus emtricitabine plus dolutegravir. TED regimen. NACO regimen is DLT. Tenofovir and dolutegravir are constant. Emtricitabine is replaced by TED has replaced by TLD basically. Tenofovir, lamivudine, dolutegravir. It was temifovir, emtricitabine, delufovir. Okay, needle stick injury, single pill at bedtime, tenofovir disoproxil, lamivudine 300. Tenofovir disoproxil 300 milligram. OD, lamivudine 300 milligram, dolutegravir. TLD basically again, but 300, 350. Here it was 300, 300. Okay, it still is the same. Prophylaxis of okay, tenofovir. Okay, tenofovir disoproxil and emtricitabine dolutegravir for 4 weeks. Side effects of tenofovir: bone toxicity. So it's basically TED regimen. And here, what are the other regimens they follow? Heart, tenofovir. Just right over here. T300 emtricitabine. T300 emtricitabine 200. Dolutegravir 50. Namibudin is 300 everywhere I see. It is basically, I call it the TED regimen. TED, TER or TLR. AED slash ALR. What? ALD dolutegravir is constant, bro. You never mentioned what's the full form of NRTR and NRTI. Whatever, this is an important question. Okay, whatever. Let's move on. Hmm. You've written the thing? Okay, Q M 1479 underscore 5. Neuropsych. Hey, psych is under me. No, no, psych is in the second paper. Sorry. Okay. So, this is one anticoagulation. It may be needed in rheumatic heart disease patient. This is a like a stock question. It's common sense when it's a pro-coagulative state. What else do you need? Twenty. Okay, it's not written over here. Rheumatic heart diseases. Let's find it out. We can find it. Valvular heart disease itself is the rheumatic heart disease. Come on, man. 73. I don't think they've written the management over there. Complication if thrombus formation. So the question is anticoagulation may be needed in rheumatic heart disease. Yeah, that's true. Okay, this is the actual one. No, this is very specific, man. This is very specific a question. Dang, this is a very specific question. If you are not reading this and going into the paper, you might not be able to do it. So, cardiology. I'm trying to have 10 minutes. Okay, valproic acid. Hey, only two questions. Done. Something is wrong with this set, man. How is it 100 marks? Okay, they changed the entire order of valproic acid is not used after neuro is a different thing. But steroidogenic beta blocker, anti-epileptics used in pregnancy. So what the fuck you trying to do, man? There's so much of noise coming up from the upper floors. I don't know what are they punching the floor or something. Seems very awkward, very weird also. Valproic acid beta blockers not contraindicated in patients of bronchial asthma. Is respiratory under me also not respiratory? What? What is the question? Beta blockers is contra obviously, otherwise you give beta agonists for controlling asthma. Why would you give beta blockers? Common sense, man. This is actually a cardio question. Beta 2, yeah, that was correct. Not useful. চার নম্বর কেন লিখতে দিচ্ছে ভাই এগুলো? হাউ ইজ দিস? Fluid management should be judicious in AMI. Okay, let's find this out. This is a good question actually. You can't use too much of fluids, otherwise what will happen is that you're just overloading the heart. Ischemic heart disease 28. 28. Let's go in 28. Let's find the thing together. Ischemic heart disease can't use a lot of fluids. There should be some reason, right? Yeah, because obviously if you put a lot, it's already the heart is running out of oxygen and you're telling it to do some more work because you're putting fluid in your oxygen. You have to be judicious with the fluid use. Mm, mm, management of lung conditions, not right. Not really. It's not written over here actually. Nitrates, beta blockers, calcium. Yeah, all of them actually act by lowering the this thing, that thing. Hmm. This thing is actually very important. If time permits, just read it up once. Hmm. All of these are involved with actually, like you want to reduce the load on the heart. All of these are problems that are happening because the load of the heart, LV dysfunction, shock, arrhythmias, all of the problems that are having increased function of the heart. You just want to decrease the function of the heart. Rainy season, I don't think there are any other reason of this thing. For now, let's take a break. भाई थोड़ा रुक तो जाओ, सांस लेने दो ना भाई, लेट मी ब्रीथ फॉर फक्स सेक मैन। I'm getting tired man, I'm just getting tired. I need 5 to 10 more minutes. This is just too tiring. I need rest, guys. I need rest. My brain's completely hanged on that. It's okay. How many hours have I been studying right now? 5 hours. Like 4 hours or 5 hours something. Should show me over here. I've been live for how many minutes? It's not showing me, right? It's not showing, just showing me 10 GBs of data which have been transmitted. Like around 3,61,000 frames that have been rendered. Big thing. Whatever, man. I'm tired, man. I'm just so tired. I want to eat something nice tonight, actually. Should I eat a pizza? Come on. Costs 230 rupees and the pizza costs 230 rupees. I don't want to waste that. But whatever, man. Uh, I really do want to start studying and I'm just feeling so tired. It's okay. You'll have to start studying. I have no other option basically. Yeah, because today and tomorrow I'll be solving the question papers. Right. Let me just recap a bit about my plan upfront. So let me just check the schedule. Okay. So here is the schedule. Okay. I don't know if you can see it or something. You probably can't. So I'm just telling you. 21st of Jan, exams are starting. Okay, medicine paper one. The next day paper two. 1 day gap. Obstetrics gynecology, which means I'll get a 1 day gap for obstetrics, which means I'll be able to study obstetrics. But gynecology I'll have to prepare from before. Okay. Then you have surgery paper one, paper two, pedia on 1 day after another. Okay, we do not have a gap in that. So, mm, surgery paper one, I'll have a 1 day gap. Surgery paper two and PDI, I'll have no gap. And PDI is huge. Okay, surgery paper two is huge. PDI is huge. Both of them. So, what I understand from here is that I have to prepare surgery paper two and PDI better. And I also have like, if I say what I'm planning is that today I'll solve question papers, tomorrow I'll solve question papers. So maybe it will be around 4, 5, like 10, 12 colleges more that I'll be able to solve, right? Which is around 120 more questions, say for example, which will give me a fair idea to where to read from. So by fifth, I'll be solving the question papers, and I'll take sixth and seventh. By seventh, I'll have finished medicine quest. Like sixth and seventh, I'll finish medicine quest, reading around 150 pages daily. It's doable. Okay, so sixth and seventh I'll finish medicine quest. Then I'll on 8th, 9th, 10th, 11th I'll finish obstetrics OBGY quest. 9th, 8, 9, 10, 11. Then 12, 13, 14, 15 I'll finish surgery quest. 12, 13, 14, 15 I'll probably go to 17th also. No, I'll have no time to go to 17th. 12, 13, 14, 15 I'll finish uh, this surgery quest. And then 16, 17, 18, 19 I'll finish media quest. And then 20 would be of revision of medicine paper 1. I hope this goes good. Okay, I hope this good. This won't be smooth. Okay, this won't be smooth. You have to accept that, and then move on with life. Yes, so this is the last round of my studying. I hope, and then I'll go into dinner for today, and I'll go to sleep. Let's hope for the best. Hmm. Hmm. Mentions indication of bone marrow examination. Oh, hey, anemia is under which paper? Hemat is under paper two, so I'm not going to go into this case. I will solve it and upload it somewhere. I don't know. Giving me a diagnostic plan of anemic treatment. Okay, elderly smoker. Okay, I should have studied this DKHHSDD. I should have studied that. Just read the basic points. Okay, you don't have to read everything. Read the basic. I think Marrow is given pretty good. I'm just satisfied with how Marrow has turned out to be. So let's just read this DKHHS and then I'll put it in there also. For some reason, my GI also doesn't seem to cooperate. By the way, I haven't seen any hemat, dharma, or psychiatry questions till now. It's interesting. Okay, DK, HHS, right? Let's let's study DK, HHS. It's towards the end of it, I should. Okay, acute complications, infections, DK, HHS infections, unit rhinocerebral mucormycosis, acute emphysematous cholecystitis, acute emphysematous pyelonephritis, malignant presence with nocturnal ache. Okay, nocturnal ear ache, risk of skull base lower cranial nerves affected, regurgitation, death, positive organism, pseudomonas, diagnosis in an MRI brain, treatment IV third generation cephalosporin, rhino. Children may provide uncontrolled diabetes plus or vital pain plus headache post COVID. Mm, hmm. No diabetic pain plus UTI. It is contrary to the this is this vomiting with tachycardia and tachypnea. Medical onset, medical acute pain abdomen. Management of detail. That's a management of decay. Okay, acute abdominal myocardial infection, decay, chronic Crohn's disease, hypercalcemia, Addisonian crisis, late in porphyria. Management of decay, hydration and water deficit decay is 9 liters to IV. Lines instead of fluid bolus. 3 liters infusion in the first 3 hours, next 3 liters in the next 6 hours, next 3 liters or next 12 hours. Another regular insulin administered dose of 0.015 unit Regular insulin increases 0.015 units per kg IV. Stead maintenance dose by IV infusion at the rate of zero point 0.1 unit per kg per hour. First hour 5 units, next 5 hour 3 units per hour, next hour 1 5 3 1. So 25 to 500 ml over 5 hours. What? Acha, 25 units regular insulin and 500 ns over 5 hours. Then next 15 units. Acha, 5 unit per hour is basically zero point 0.1 unit per kg per hour. Now, if the thing is, hmm, last 5 regular insulin should be administered subcutaneously. No, person 40 units of insulin per day is no. So 40 units is divided into 24 hours of short acting insulin during the days, further divided into 8 unit, 8 afternoon, 8 evening, and 16 units. 8 short acting, 16 long acting, 8 24. Potassium replacement pushes key% of the cell which needs to be corrected. 1 ampule KCl for every 1 liter of fluid. 1 ampule KCl for every 1 liter of fluid plus 1 ampule KCl is equal to 10. 1 ampule is equal to 20 milliliter. ঠিক আছে. Never start insulin without checking the potassium level. Where the fuck is the potassium level, you stupid piece son of a... Oh man. You guys, right? This is like crime, man. How can you miss this? Come on, man. This is not done, yeah. But it is absolutely not done. It's too bad. I think rather Quest has it written better. It's unfortunate if Quest has it written better than Marrow. Dude, you guys take 60,000 rupees in 3 years. If you still don't have it, it's bad. Hardware was non-ketotic. This is non-ketotic, right? I need a DK management. Okay, this is actually better, I think. Yeah, this is best. Quest has the best DK management, hands down. This won't work. I'm stupid. I think I'll do it at 333. 1 liter for 3 to 4 hours, then change to 0.45 initial 250. It's down to 250. And yes, 1 liter for 3 to 4 hours, then 0.5 glucose down. Further slow it down. On narrow, it's different. Wow, what do you write? Mero is saying one thing, Quest is saying another thing. What do you write? Wow. Says 0.1 kg per hour and bolus is 0.015 units per kg. 0.15 units per kg. Then 0.1 by infusion pumped. What they should say about this, no? Wow. Then why will I give the insulin? In fact, I think you should give insulin dose to initiate when insulin decrease serum potassium. 1 ampule with 1 liter of fluid. This is so very weird, man. There's no bicarbonate therapy over here. Fuck, man. Bicarbonate 50 ml of 5% close infection with treated. Okay. It's very pathetic. It's such an emergency like a diabetic ketoacidosis, and the two sources which I have are like at a lot of differences with each other. One. I'm amazed that hyperosmolar non-ketotic coma has almost the same management as DK. What is the difference that happens in DK? I forgot. I think it was the same management, just a slightly different treatment. Is hydration is at a slower rate than DK. NS is avoided because the 5% half normal saline is more preferred. Yeah. Okay. Okay. 5% dextrose is more preferred, but the rest everything is almost the same. Okay, I get it. This is from Q248 to 251. Okay, Q248 to 51. Q. Hmm. Anemia is very deep, and indications of a bone marrow examination. I shall look into that. I think it's written over the indications of bone marrow biopsy. Okay. Elderly smoker, life with hemoptysis. What's the probability? Okay, again, lung carcinoma. It's goes off to Asia. Is nephromyopathy and nephro is my part. What are the stages of CKD? What discuss the etiology of chronic fever. Let's see if we have it right over here. If we do not, I know where to find it at least. Genetic urinary. This stage chronic kidney disease. Okay, 109 stages. Let's see. It's, the answer is there. I don't think the answer is there. But still, let's see. Oh, it's there. Discuss the etiology of chronic renal failure. Stages are here. Hmm. They ask for etiology of chronic renal failure, it seems. Okay. It's not there. Let me just check it again. Mhm. Really is a very vast answer, to be honest. System does make it falls off quickly. It seems like sometimes. Nutrition that is like it's nephrology. Kidney, chronic kidney disease. Should have something with it. Chronic kidney disease, 875. RT is something which I still don't understand. The type 3 RT is what type this type that RT. Chronic kidney disease causes. Yeah, found the etiology. Wow. Yeah, found the etiology. Yay. Clinical approach to CKD. Blah 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 blah. Blah. Symptoms. Blah blah blah. And there you'll find the stages also. I think if I'm not wrong, there has to be stages of CKD. It's impossible. I think this is the one stages of CKD. Okay, I can't understand anything. Okay, this is the stages. Quest is insufficient. This is the one. Okay. What does this mean? Classification of CKD. Yeah, this is the better classification, right? Yeah. Task for. Yeah. This is what has been asked. Why did I do it? Oh, I wrote something wrong over there. What was the previous semester question actually before this? Elderly one matter examination, AMI, CKD. What are the stages of CKD? Okay, sorry. I think I'll prefer this answer actually. Okay, so what are the stages of CKD? You have three things. Okay, so you have to classify on the basis of albumin creatinine ratio as A1, A2, and A3, and also on the basis of GFR. So if GFR is greater than 90, hmm, are you walking the right path? Yeah, if GFR is greater than 90, G1, 60 to 90, basically it's a 30 drop, and then it's a 15 drop, right? 30 drop, and it's a 15 drop, and it's a 15 drop, and it's a 15 drop, it's a 15 drop. So first drop is 30, 30, 15, 15, 15, 15. This is what it is, right? 30, 15, 15, 15. Okay. So G, in the course sense, this is actually still 30. G3 is 30. It's just the for some reason decided that 3 and 3B sounded very good. G1, 2, 3A, 3B. Moderate, mild moderates, not mild moderates, mild moderate reduction, moderate severe reduction. G3A, G3B. This is MJNMCH8, and this is also MJNMCH8. Okay, and so basically A1 is less than 3, mild to normal increase. 3 to 330 is moderately increase, and greater than 30 is severe increase, like albumin creatinine ratio is through the roof, right? So 30, 30, 15, 15, 15, 15, 15, and yeah, it's basically kidney failure at G5. So you go to G1, 2, 3A, 3B for some reason, I don't know, G4, G5, right? And then you come into the reasons of what are the causes of glomerular nephropathy, proliferative glomerular nephropathy, crescentic glomerular, membranopathy, mesenteric glomerular nephropathy, systemic and metabolic disease, diabetes, SLE, polynodosa, PAN, basically PAN, SLE, gout, amyloidosis, interstitial, chronic interstitial nephritis, chronic pyelonephritis, analgesic tuberculosis. What is analgesic tuberculosis? Okay, analgesics and then tuberculosis both affect the interstitium. Nephrocalcinosis affects the interstitium. Okay, obstructive. Basically, anything which you can think of, anything which happens in the kidney model is over here. Okay, obstructive calculus, tumors, retroperitoneal fibrosis, prostatic enlargement, vascular, essential hypertension, accelerated phase, renovascular vasculitis, SLE, panscleroderma, again, vascular problems, congenital polycystic kidney disorders, Alport syndrome. Yeah, Alport is hepatorenal, I think. No, it's lung, pulmonary renal syndrome. What are the hepatorenal syndromes? I forgot. Okay, let's check it out. Nice thing that you these things come to you. Good. List of hepatorenal syndromes. What is this one and two thing? AKI, non AKI. I just want a list, man. how do you divide this thing? What is hepatorenal syndrome? Yeah, we can imagine Newton. Let's see if we can find it in our. Oh, yeah, hepatorenal syndrome. What does he say? We will. Um, yeah, so what's the pathophysiology? Damage to the liver, causes portal hypertension, causes blood vessels dilate, reduce blood flow to the kidneys, basically. Okay. Hmm. Okay, I get it. So the entire video he spent out yapping on this thing. We can't fault him though. I would have done the same thing. There's nothing. Pulmonorenal syndrome. Pulmorenal syndrome. Pulmorenal syndrome. Okay, Wegener, Zanka, SLE, good pasture. See, there are so lot of see Wegener, SLE, MPA. Yes, yes, the effect. I had to revise my vasculitis again, man. Oh, Wegener's. Yes, 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 yes. Okay, so I've got the answer right. Let's just write the answer down and update this area also. We'll do this. Let's go to genito urinary system, right? Then we'll find the question paper. We'll take a screenshot of it. But I don't know what to write for 4 marks over here, man. This is 4 marks is too much. Hmm. Yeah, solve the question. Move on. Write down the best possible option. I can't get into this shit, man. Which beer is salt? Okay, damn. That feels good. Diamond Harbour. It's why does the question paper crumple like this? Maybe, bro, you don't love your college or something. There's some problem with your college, it seems. Draw a schematic. Oh, who comes up with this question, man? Bro, you're pathetic, man. Who tells it to? Oh. You're in for a treat, man. This question paper. Draw a schematic diagram of glomerulus. Wow. I don't think these books also have a schematic diagram of a glomerulus for some reason. Let's see, I don't think they have glomerular diseases. Yeah, I would be amazed if they do. I don't think they do. Let's see. Always find out new things daily. Right. What a treat the question paper has been. Wow. Just wow. And the dude who took the like image of the question paper really needs to chill, man. Diamond Harbour Government Medical College and Hospital. Them schematic diagram. E. I don't think it's enough actually. How many marks? No, no. This is very less for or this thing. Wait, I have a call to pick. How would you differentiate between acute and chronic renal diseases? What do you mean how to differentiate between acute and chronic renal diseases? History, if you have a very long history, it's a chronic. If you do not have a very long short, if you have a short history, it's acute. I don't get it. What are you trying to say? Absolutely do not get it. Just let me read it through. Just mark it over here. I think this is probably the worst question paper setup that I've seen. Diamond Harbour is going to be the worst. Mm, gram negative bacteria, systemic vasodilation. Okay, so I've done up till half of Diamond Harbor started with. Hey, I forgot to update this thing, man. This is bad. Diamond Harbor Government Medical College. Yeah, and it was 4 out of 4. I forgot to update it. So yeah, 4 Pomodoros, 4 hours of studying. I guess this was effective. Completed, I think, 3 question papers. I think, if I'm not wrong. Yeah, CNMC, Kuchbihar, Diamond Harbor, half, not completely. Half I have completed. Let me see the other questions. And this is not my question. Lactulose used in hepatic cancer. This I know, to remove the bacteria, like to move on the stool. Otherwise, the bacteria create ammonia. So the ammonia couldn't be, like in normal conditions, the bacteria produce ammonia. The bacteria which are resident in the gut produce ammonia, but they're broken down by the liver. But in a condition of hepatic encephalopathy, the encephalopathy is obviously happened because the liver is not working. So now the ammonia which is being produced by the bacteria would not be able to be metabolized by the liver. So you want the bacteria to just move on, to just go out of the gut. So hence you put in lactulose. That this like AC inhibitors are contraindicated by because then they precipitate AKI, because already it's renal artery stenosis, and the AC inhibitors also do stenosis. So hence it's contraindicated. I think that's the reason. Clinical features of complicated Vivax malaria. This I have to see. Critical phase of dengue. This I have to. Critical phase of dengue, I know. Like the time when the fluids are all going out of the cells, and like you're having features like hypovolemia and hemorrhagic fever, hemorrhagic shock. You're going to that kind of a thing. You have a huge thrombocytopenia, that kind of a picture. That is the critical phase of dengue. I can write this. I can clinical feature of complicated Vivax malaria. I think they're talking about this cerebral malaria, this that kind of a thing. That is complicated Vivax malaria. Like they have convulsions over there, fever which does not decrease down. I think that is the picture which they are talking about. So yeah, the rest of the people won't take long. So I think we have done pretty good. So